Good evening, everybody, and a Happy New Year to you all, if it isn't too late to say it. This is the meeting of the City of York's Health and Wellbeing Board, held on Wednesday, the 19th of January from 4:30, and I'm very pleased that everybody is able to come. The meeting is being webcast, and I won't ask everybody to introduce themselves individually, but to introduce themselves as and when they speak. We've had some apologies. Joe, would you like to go through that for us?
Thank you, Chair. Yep, so we've got apologies from Councillor Craghill, from Sharon Stoltz, who Peter Roderick is substituting for, also from Alison Semments, who David Harborne is substituting for, and we've also had apologies from Stephanie Porter, Sean Jones and Mike Padgham.
Thank you very much indeed. That's very helpful. Now, the first item is, has anybody got any declarations of interest that aren't already declared on the council website? If you have, would you be kind enough to raise your virtual hand or your real hand? No extra declarations. That's good. Thank you very much. The next thing, agenda item 2, is the minutes of the meeting on the 17th of November. And I have got a couple of things from that. Minute 65, the Multiple Complex Needs Network. I gathered discussions have started as to how the Health and Wellbeing Board and the York Health and Care Alliance can jointly undertake a cultural values survey process. Tracy, do we need to say any more about that at this stage?
No, I don't think we do, Chair. I can provide a fuller update when I know more.
Thank you. And then minute 68, Sean, this is the Health Watch report on GP services. And we were very aware that it was a very small sample because of COVID. And the partnership coordinator wrote to relevant organisations. And I wondered, Sean, if you'd had any responses.
I got a direct email from Dr. Emma Broughton, who's also here today, suggesting it would be helpful for us to work together on that. I didn't actually reply until the beginning of this year for a variety of reasons, but I've agreed it would be really helpful. She introduced me to a couple of colleagues, one of whom, Dr. Abby Brooks, I think will be well known to anyone who engages with social media because she's doing an awful lot of good publicity about what's happening in primary care. So we will be picking that up, and we are determined to do something else around GP access, but we want to make sure we're really sort of making sure we're hearing from those people who are most likely to be experiencing challenges to make sure it is of the most value. I think it's also fair to say a lot of the discussions around the Humber Coast and Vale integrated care system are looking at how we tackle health inequalities and what networks could be established to support with that. So I think there's sort of what's the opposite of a perfect storm? A perfect opportunity, a golden moment to be thinking collectively and creatively about how we harness the voice of people best to shape the future of health and social care in our city together. So there will be more to talk about in future, but I think for now we're on with it, we're thinking about it, and we'll tell you more when we know more.
Thank you, Sian. And when you do want to bring something back to Health and Wellbeing Board, you'll let Tracy know, won't you? With those two comments, are we happy to accept those minutes as a correct record of the last meeting? Lots of nods. Right, thank you very much indeed. Public participation. I understand, Joe, we have nobody registered to speak at this meeting. Is that right?
Yes, that's right, Chair.
Thank you. So we'll go on to agenda item 8. We're altering the order very slightly, but this is a verbal update from Fiona Phillips as the AD in Public Health, and that's due, we're changing them around because of people's availability. Fiona, would you like to start us off?
Yeah, thank you, Chair. So this was to just give a update really in terms of the COVID situation in York. I do have some slides that I can put on screen if that's easier, just for people to visualise when I'm talking about numbers and rates and stuff. So I'll just put those up now and we'll just talk you through those. So hopefully you can see this on the screen now. So what you can see is that our case rate in York has been dropping, almost dropping as quickly as it went up, in fact, and our rates are now lower than both the England and the regional rate. And what you can see is actually we've got the lowest rate in the Yorkshire and Humber region at the moment. So quite positive signs at the moment in terms of case numbers. Obviously, case numbers are not the only thing we look at, and I'll go on to talk about some of the other indicators. Just in terms of where we're seeing cases at the moment, so we have seen an increase again in our younger age population. Over the Christmas period, it was in the sort of 25 to 40-year-old age groups where we were seeing most cases, but since schools have gone back, it's gone up in those younger age groups, and particularly the 5 to 9, who are our sort of unvaccinated population. Just then, so the other things that we look at, obviously hospital admissions. So as the cases went up, we did see an increase in people in hospital, and they dropped very slightly at the start of this week. So whether that's the start of a continuing downward trend, probably a little bit too early to say just yet. But obviously, as you can see, if you compare the numbers in hospital to this peak that we saw this time last year when we had an increase in cases, obviously we've had many more cases in this peak, but it hasn't led to quite as many hospital admissions, and that is in large part due to the vaccination programme. And also the other thing that you'll note there is we haven't seen as many in ITU, which again is partly because of vaccination and also the various treatments that we have for COVID now as well. And then the other thing that we will look at is deaths from COVID. So we saw a very small increase in deaths due to COVID. Obviously, you know, we don't want to see any deaths from COVID, but it's been a much better position than, again, as I look back to comparing with last year. So, and when we look at deaths from all causes compared to our baseline, we're kind of tracking as to what we would normally expect to see at this time of year. So just some of the other impacts on the system within York. So we've currently got 13 care homes where there is confirmed cases, and so they're in a kind of outbreak situation, so unable to take admissions, which obviously has impacts on the wider system, particularly in terms of discharges from hospital. And then the other setting there, just mentioning again those cases within school age children. We have had 2 schools in York that have had to close year groups, and that has been due to cases within the teaching staff, and they're unable to open those year groups. So again, that has an impact onto workforce, and often health and social care workforce, when they're having to look after children at home. So the vaccination programme is continuing to roll out. Obviously, we had the big push over the Christmas period to get people in to have their booster dose. So as you can see, they've got good uptake for the first dose, drops off a little bit for the second dose. And then the booster vaccination, we're almost up to 70% on the booster vaccination, but obviously still wanting to do more to get people to come forward and have that booster dose. You've got the figures there for the 12 to 15-year-olds. So uptake of the first dose has been just over 60%. We would obviously like that higher, and we've been doing lots of comms around that. Most of the 12 to 15-year-olds in York who had the first dose, they're going to start to becoming eligible for their second dose sort of from now until around the end of January, early February. So we'll then be able to report on uptake of second dose in that age group as well. And then what you can just see from this is as you go down the age groups, the uptake drops off. So really good uptake in the older age groups who we know are the most vulnerable, but it does drop off a bit in some of those younger age groups. And then we see a similar picture when we look as well at uptake by area in York. So we know that some of our deprived wards have got lower uptake. So there's been a lot of work happening to put on particular pop-up clinics, try and target it to those areas of deprivation or where we know uptake is not as high. And that is a kind of ongoing programme and lots of work being done by colleagues in the NHS around that. And so that was all that I wanted to share data-wise, but I'm happy to answer any questions that anyone has on any of that.
Before we go to questions, as we've got Simon Morritt with us, Simon, would you like to give us a brief comment on the situation in York District Hospital?
Bear with me to get to mute off. Yeah, I think it's as Fiona said, really. There was a slight dip at the beginning of the week. That hasn't. Where are we? We're Wednesday, aren't we? That hasn't been maintained as the week has gone on. We've sort of plateaued, really. But one would hope with the fall in incidence that shortly after that we should start to see some significant reductions in terms of our admitted numbers. Overall, we've currently got 147 patients who are COVID positive across all of our sites, and we've sort of been in that position really for the last 2 to 3 weeks or so. But we are hopeful that it will start to fall. The biggest issue for us and the biggest challenge for us with Omicron has been staffing, because it's such a transmissible variant. Our absence rates have been 10% plus at times post Christmas, so that's proved to be the biggest obstacle to us, obviously delivering the care that we would want to. That came down actually this week, which is good news. It's down at 8.4%. Obviously, we'd like to get it back down to around the sort of 5% mark, which is where it was before we went into this wave. Other than that, though, nothing else really to add, Councillor Runciman.
Thank you, Simon. That's very useful. Councillor Looker, you wanted to ask something.
Yes, I've got 2 points I'd like to raise. One, I mean, I don't know, it's, can I just say this isn't a criticism. I just wondered if your analysis gave any indication of how many patients catch COVID after they've been admitted into hospital, because I gather anecdotally there is obviously, in a sense, it's a risky environment at the best of times, but I just wondered whether we had an analysis of patients that catch COVID from coming into hospital. But my second question is more practical. Looking as I represent the Guildhall ward, which is down at the very bottom, among the very bottom of your take-up. And I wondered if there might be an opportunity for us as local councillors and team members working in Guildhall to have a discussion with somebody as to how we might promote, help, facilitate opportunities for vaccinations. It's very difficult to get at why this is happening. We have a very mixed population. Some of it is very transitory, but I wondered if there might be an opportunity for us to have a Guildhall focus opportunity with somebody within the vaccination team.
Thank you, Janet. I'll ask Simon to respond to the first question about people being diagnosed with COVID after they have been admitted. And I'll ask Fiona to respond to the second question about briefing local councillors, local ward councillors. Simon?
I mean, we do have that data. I don't have any with me, so I'd be quite happy to follow up post-meeting to share some information. But clearly, patients, particularly Omicron, is a very transmissible disease, and we do, obviously we test all patients who are admitted into the hospital, and we test them at regular intervals. So we do find that patients test positive after they have been admitted into hospital. But I don't have any data to share with you with me today. But more than happy to follow that point up.
Thank you, Simon. And Fiona?
Yeah, so I can certainly take that offer back. There are members in the team who work with Nimbus Care and the CCG in terms of looking at vaccine inequalities. So I will take that back to them to have that conversation. Obviously, whilst doing the vaccination programme, and particularly the big push over the Christmas period, they were trying to get feedback from people, in terms of access to the vaccine, what would maybe put people off coming forward. So we're starting to get some intelligence around some of the reasons, but it's complex. So certainly any avenues that we can explore or other routes into having those conversations with people about the vaccine, we'd want to take up that offer. So thank you for that.
I would really appreciate that, Fiona, because I think, some of the issues are, in a funny sort of way, the main vaccination site is quite tricky for some of the Guildhall residents to get to, especially as there's often a very low car usage in Guildhall. But some of the opportunities for pop-up centres, vaccination points, hubs are very rampant in the city centre. So it'd be useful to have that conversation with somebody. And thank you, Simon. It was part curiosity. It's one of those things that pops up every now and again, and you think, that's interesting. I suspect you're right. It's absolutely inevitable. But thank you very much, both of you.
Good. Thank you, Janet. And Fiona, I'm sure, will be in touch. Sian has a question.
Just a couple of things that have come up in recent conversation. We've had a number of people contacting us about the challenges of transport. It actually links quite closely with what Janet was just describing about not being able to get out to the vaccination site. And I know we are doing pop-ups in places, but I also know communicating that effectively to people at this current time is potentially more difficult because we're not seeing people face to face. We're not doing as much direct engagement sort of on the streets. We're not going to community centres in the way that we were before. So kind of getting the message out that there might be alternative places available for people to get those vaccinations. I think there's still potentially more we could do to encourage that. And a lot of people have said they have felt that the only option was to go to the vaccination centre. So if they can't, they're not going to do it. The other question was about for people who are severely immunocompromised, they'll have already had 3, won't they? But they are now coming up to the point where they can get a booster. And is it true that there are problems with the national system for being able to book those boosters at this time? Are we aware of that, and are we challenging that? Because that's something people have come to us and said, is that they think they're now eligible for their booster. They've had 3 already, and the current system won't allow them to book their booster. And I know Community Pharmacy have said to us that they're quite interested in knowing if they can play a role in addressing both the location issue around availability of places that we can do it and the vaccination for people who are immunocompromised, bypassing the system. But it also felt like if we have a system that is recording who's had the jabs, it would be useful for that to work rather than bypassing it. So yeah, two questions there.
Thanks, Sian. Yeah, I think it could be Fiona, it could be Nigel, it could be Emma. Who'd like to go first?
I'll just come in and say about the communications. So lots of work going on. Obviously, some of it does rely on people following the council on social media or the CCG on social media, which we know, not everybody will do. So we try to look for other opportunities. So we do every couple of weeks a slot on local radio and try to get those messages out. We have also done leaflet drops from our outreach workers who also deliver lateral flow tests out out to the community, and they'll do leaflet drops when we know there's a pop-up clinic in a certain area to really target, to try and they'll just post that through everybody's door so that people get to know about what's happening locally to them. So yeah, we try and do that as much as possible, but like you say, sometimes it is just word of mouth and trying to get that out. I can't answer the other question about the booking system, so if Nigel or Emma know more about that, that would be helpful.
I can come in to say I don't know.
I do
more about that, so Emma might.
So on both issues, as Fiona said, Fiona's talked about the public health angle. Obviously, primary care has also, Sean, I'm sure you know, taking a very active role. So just to kind of look it up from the vulnerable communities, I just want to kind of stress we've the learning disability cohorts have all had individual phone calls. So we've been very active in looking after the vulnerable cohorts. We've had the social prescribers supporting us through the COVID hub, in general, looking particularly at dementia patients and vulnerable outreach to make sure they get the housebound campaign. And across Nimbus and all the practices, we have done a massive outreach campaign for the housebound. It's been logistically difficult, but we have done it with an awful lot of support of volunteers and support. So we have got out to hopefully some of our most vulnerable. You're right, we've got all the pop-up services, and just to be clear, they're all available on the national booking system. So it just requires that first step of the commitment to try and book. So whether they book via 119, whether they book via the online book a vaccine, all of those outreach hubs are available. But I guess it's just reminding people that the only option is not necessarily at the Askham Bar hub, which of course has the most hours of all the sites. But just to clarify, all those other sites are still bookable. Clearly, we're putting up pop-up tents in a lot of those vulnerable areas. We've been looking at Hull Ward as well as Guildhall about where GP services can do some targeted events. And in general practice, we've got ability to text out to batch patients that live in a certain hotspot area. So we're just to say, primary care is also doing its bit in trying to address the cohort there. As for the third vaccines, this is a lovely, fairly simple message. No, there are difficulties with the booking system, but all these patients, if they identify themselves to primary care, we are able to send them a message that they can show at the mass vaccination or at any site where they can just walk in and have the vaccine. So if anyone is having difficulties, Sean, that you're aware of, please signpost them to us. We can help. And all they need is just a verification from us, and we will send them a message. We've got it all set up to say, yes, they're due. But essentially, it's still a booster, but they've had 3 primaries and then they're due a booster. And I know a similar system, Nimbus will accept anyone that's got a letter from the hospital. So a lot of these patients aren't necessarily advised by general practice. They're advised by, say, their rheumatology specialist or their cancer specialist. If they have, again, a letter saying, I have 3 primaries and I need my booster, again, that will be accepted at any site. So it's a harder message to get out there, but just if you can help us spread that message, we'd be much appreciated, because clearly they're a group we really want to ensure that they get the vaccine.
Thank you, Emma. It's really good to know so much is going on, and particularly that so much attention is being paid to people who are particularly vulnerable and people who might be reluctant to take up the offer of vaccination. And that's a group that's very important to get to. Any more questions? No? Right, thanks very much. Fiona, if you have to go, we should quite understand. Then I'd like to go on to agenda item 6, please. I did say we were going to be all upside down in the order. Now, this is the establishment of a Children and Young People's Health and Wellbeing Programme Board. And people who got their papers by post might have found that Annex A was in the main papers and not with this particular item. And if I remember rightly, the Annex A that it refers to is on page 33. So that might help a little bit to try and get it sorted out. I think, is it Fiona and Anne? Sorry, you can't go yet.
I can't go, no.
No, you can't go yet. So would you like to start off on this one, please?
Yeah, thank you. So basically this paper is seeking approval from the board to establish a Children and Young People's Health and Wellbeing Programme Board as a subcommittee of the Health and Wellbeing Board. So some of you will perhaps remember that previously we've had the You're OK board, which had a role in delivering the priorities in the health and wellbeing strategy. But that board hasn't met since 2019. So the feeling is that there is a need to develop a strategic board in York to take forward our local priorities, but also to link into some of the new structures within the integrated care system. And ensure that York as a place features in that wider system work and transformation work that is going on. So we have had a number of conversations locally about setting up a strategic partnership and this board, and we've also had a workshop to take that a bit forward, and then a follow-up meeting after that. As part of that work that has been done, we've developed a draft terms of reference, and that was attached in the papers, so hopefully people have had a chance to look at that. But what you can see from the terms of reference is that the main objectives that we're proposing for this new board are to have oversight of delivery of improvements to maternity, children and young people's health and care in York, as well as some of those transformation programmes, to really kind of set the strategic direction to improve health and wellbeing outcomes for children and young people in York. And seek to influence some of the wider things that we know impact on health and well-being, so things like poverty, housing, etc. And in the terms of reference, we also list some of the principles by which that board would work. So, for example, things like reducing duplication, reducing inequalities, taking an asset-based approach. So some of those sort of general principles. And then we've also put a list of the core functions that we would see that board would have. We've also in the draft terms of reference listed what we think the suggested membership of that group should be. And so what we're really asking, as I say, is an agreement to dissolve the You're OK board. And just to sort of be clear on that, it's not the You're OK brand. So some people will be aware that there's a You're OK website, which is owned by Children's Services. So we're not talking about changing that, but just dissolving that You're OK board, and then approving the terms of reference that we've shared. Obviously, if people have got any comments or want any amendments to any of the documents that we've shared, we can have that conversation as well. Thank you.
Questions and comments to Fiona, please. Councillor Cuthbertson.
Thank you, Chair. Welcome this very much, and I've got a slight concern there may be the odd function that we haven't spotted yet that's hanging over from the former You're OK board, but nothing's crept out of the woodwork too much. I think the very interesting thing about this proposed programme board is that the Early Years Improvement Board, which met this earlier today, was quite well seized of the need to do some tidying up in its area. I'm using that word less than scientifically, I'm sure, but nevertheless, there are many opportunities, and those allied with some current initiatives such as Early Talk for York and the partnership with Nesta and Look, Say, Sing, Play give us the opportunity to do a much more coherent piece of support for both the PVI sector and early years with our health partners and with the schools that are involved. So partners are looking forward to this in the improvement board, and I don't know whether the Director of Children's Services has got anything to add to that, but it feels promising. And if this decision is all we need to do to implement this subcommittee, then that's fine by me. Tracy may wish to comment on that. Thank you.
Yes, thank you. I will bring Anne in a minute, if that's all right, Anne, and then I'll bring Tracy in, but I've got a lot of hands up, so I'm going to start with Naomi.
Thank you, Chair. I think first of all, I just wanted to express really support for the proposal. I think it makes sense. I think the challenge that we've had within the City of York, some of the complexity around children and young people, I think this is a really positive move. I wondered whether in the terms of reference, whether we need to make reference to the theme from their health and wellbeing strategy around starting well and growing well, just incorporating that into those terms of reference. And in terms of membership, just given some of the significance of some of the challenges we've faced, and obviously I know that we've got a Tube representative on there, but I'd also be happy to be part of that membership. Thank you.
Great, Naomi, thank you. I'm sure Tracy will make a note of what you said. Next, we've got Janet.
Yes, thank you. Oh God, hang on, I've just got to plug myself in. It shouldn't take me more than a minute. Right, okay, I'm in. Two things I wanted to comment on. I mean, I've been a long-standing member of the Euro-K board in its prime, and I've chaired it in my time, as well as sat as an ordinary member of the Euro-K board. And I have to say, I thought it always provided a very useful meeting space for a whole cross-section of people interested, committed, and involved with children and young people. Now, I appreciate this is a slightly different animal, and it may, over time, evolve. And I would say this is probably not a fixed and final discussion of it, but that it may, as it in a sense, as it evolves, as it starts to do things, it may realize there are people missing, or that there are functions that are missing. But I have to say one very significant function that was omitted, and that is looking at the local councillor representation. It is entirely made up of the two lead members from the executive. The Euro-K board, as Councillor Runciman will remember, always had a representative from at least one of the opposition groups, sometimes from two, to enable a proper cross-party, cross-agreement along what was happening in a very, very important area of local government and of health's work. And I think it is a serious omission that you have not put on anybody. I always feel I have a very strange representation on Health and Wellbeing Board as just about the only opposition person, technical opposition person. I try to be positive, that sits on it. But it is important in these areas that we do get as much as possible cross-party engagement, and you don't get cross-party engagement if you leave one or two groups off completely. So I do hope you will go away and look at that, because I would seriously think it's a real omission. I'll be interested to see who you're looking for in your schools and schools and education representatives. We always had very good engagement from a senior member of the York College team, who was able to give us an awful lot of very interesting analysis and work that the college were doing with young people that are, in a sense, transitioning between children and children's services and on the edge of becoming adults. And I thought they gave a very, very useful and very committed contribution to our discussions. So I'm not sure it's you're not precise as to which groups you're looking at for your schools of education. But as well as representing schools, I do think the colleges have a lot to offer, as in actual fact do the universities. I know we got some very, very good engagement at one point from both the universities around young people's mental health, because we were finding very, very significant stresses on young adults' mental health. And that meant that sometimes the universities found themselves picking up issues that they didn't always feel they were competent to deal with. So I think it's a good start. It doesn't replicate your OK board, but I think there are some areas where you could just have a look, particularly at the membership, and accept the fact that the terms of reference are going to need to be flexible, need to be a bit fluid while you get yourselves established and entrenched, shall I say, so that I hope there is opportunity for a bit of flexibility as you go along. Thank you very much.
Thank you, Janet. I think you make some very valid points. Certainly when I chaired the You're OK board, we always had the opposition there. I'm sure we will look at that, but I would like to say there are opposition representatives on this board. Unfortunately, the representative of the Green Party can't be here, because I've always wanted it to be a multi-party representation. But we'll take away your comment.
With respect, at the moment, the Green representative is not opposition. And I know why she isn't here, because she's at a meeting.
Yes, I understand. Yes. Yeah. Right. Two more speakers, Sian and then David, and then I'll bring in Anne and Tracy.
Yeah, I was just wanting to say, I think, again, as Naomi's already said, this is a very exciting development. I think I understand that the You're OK board had its time. We were a member of the You're OK board and we're not on the new terms of reference. I appreciate it's impossible to have everybody around the partnership board, so it might have already been considered within the discussions. It might be that you're hoping will feed in through the CVS representative, although I would say representing the voluntary and community sector and the voice of people might be quite a challenge. But I just wanted to say that if we can be of use, if we are helpful to be included in that terms of reference, if there's still the opportunity for more people to be involved, then I would very much like to have a Health Watch person involved in this, particularly to give us the opportunity to follow up things like our Listening to Children and Young People report around health and social care services that we did. And we do have plans to develop what we do with young people further over the coming year, so it might be quite timely, and I think we would benefit from being involved with the wide range of people around the table. But like I say, I do appreciate it's impossible to have everybody, so I know that might not be possible, and we'll have to, if that isn't possible, we'll have to think about how we manage it.
Yes, thank you, Sian. I think having the voice of children and young people is extremely important, so that's another thing we'll have a look at. Thank you for bringing up the point. David.
Thanks very much, Councillor Runciman. I'm effectively echoing points already made. I too would like to see Health Watch represented, if at all possible, because as Sian has already said, the CVS sector is very large and very diverse, and we need to make sure that we're looking in more than one direction. The other point I wanted to echo was about involving the colleges, which Councillor Looker has already raised. I'm a governor at Selby College, and I've always been impressed by the way in which that college has responded to the growing need to support young people at a time when the pressure on formal CAMS services is greater than ever before. And I know that the same is true at Askham Bryan College and at York College. And therefore, it's important that we keep those networks very closely involved. There are also connections, particularly with York St John in the case of Selby College, because there are programmes and courses there that provide opportunities for people on a voluntary basis from York St John to support the student services at the colleges. So essentially, I'm really supporting what Councillor Lucas said. It's really important that one of the places for education should be for the post-16 sector. Thank you.
Thank you. Anne, would you like to come in now?
Sure. So nice to meet you if I haven't already. I'm the statutory DCS and have been with you in York since the beginning of October. It's really great to hear your enthusiasm about the subgroup to the Health and Wellbeing Board. I've been a real champion of this since joining you, so that we really, in this really complex landscape of what's happened to our young people these days, to really have a proper focus on them. And also really good to hear the mindfulness around older young people, as well as the first 1001 days of a child's life. So I'm really excited about this. I think it's a real opportunity for us in York to really have a focus on what in the end will be our next generation, and hopefully next members of this kind of board, if we get that right for them in their earlier part of life. So thank you. It's really good to listen to you and to hear your support for this moving forward.
Thank you, Anne. Tracy, do you have any comment?
No, I don't think I have any further comment. There's been a lot of interesting suggestions, which we will take into consideration. Obviously, I'll probably meet with the chair and with Councillor Runciman and Councillor Cuthbertson to look at all those suggestions. And if Health and Wellbeing Board are minded to approve the establishment of this board, then I will set the ball rolling for meetings to be arranged.
Yeah. And you wanted to come back in?
No, apologies. I was just thinking we have an agenda on this evening about the impacts of drugs and alcohol. And I guess I would just encourage you, as we go into that agenda, to really have the thinking around children and the impact of what is very much an adult-based report on the fact that children are really seriously, significantly impacted by it. So something like a subgroup of the Health and Wellbeing Board will really take that subject and think about what does that mean for children, because a vast majority of the people we're going to think about in that report are parents and carers, really.
Thank you, Anne. Are there any dissenters from the establishment of this board, or can I take silence as agreement? I can, thank you. Right, there's something else we need to say. Sorry, Councillor Cuthbertson, do you want to come back?
I was going to ask Chair if you wanted a proposal.
Oh, I do, yes. Are you proposing it?
I think I'd like to propose it, and given that we should bear in mind what has been said regarding the involvement of agencies who deal with older, younger people, and also the involvement of Health Watch and potentially the colleges as well. The point's been rightly made that it's probably going to have a flexible existence during the first few months of its life. And I can see us coming back with possibly some revised terms of reference. But I think that this body, it's overdue for an inception, and I'd like to propose that it happens. Thank you, Chair.
That's lovely. I think everybody agrees with you. There's just one more thing I want to say, and that is when it will report back to the Health and Wellbeing Board. Now, I've been talking to Tracy about this. In March, we've got the Mental Health Partnership reporting to the board, and the dementia strategy will come to that March meeting, as far as I know. And then in May, the Aging Well Partnership will report to the Health and Wellbeing Board. So my suggestion for comment by Fiona is that the new Children's Programme Board will report in September. Fiona, do you think that'll give you time to get everything started?
I think that would be great, and that will give us an opportunity to have finalised all of the stuff we've talked about today, terms of reference, membership. But I think by that stage as well, we would have a really clear report back to you in terms of what our priorities are and what work we've started to get underway.
Thank you. That's fine. In that case, that's what we'll do. Right, now we go on to agenda item 4, which is the JSNA annual summary. And I think that's Peter and Phil Truby who are presenting that. So who's starting? It's great when there's silence, you know.
I think that was me. I think Peter did unmute there, but
Oh, Phil, good.
I don't think we could hear you, Peter. Sorry. So, it is me who is presenting here. I do have a short presentation, if that's okay, Chair. So I'll share.
Yes, it is, Phil. Thank you.
I'll just share my screen. This is where the technology fails me. There we go. Can everybody see that? Is that okay?
Yes, thank you.
Yes, wonderful. Okay, so I'm Phil Truby. I'm one of the public health specialists, and I have taken on responsibility for leading the JSNA within the public health team. It previously sat with Nick Sinclair and Jen Saunders, but we've had a change around of priorities, so it now sits with myself. So this is just a brief overview of the paper that's also submitted alongside this. So recent developments in the JSNA, the working group that sits behind the JSNA now sits as part of the Population Health Hub steering group. The Population Health Hub is similar in its membership in terms of it's a multi-agency network. It's got representation from across the authority, the Vale of York CCG, York Teaching Hospital, TUV, North Yorkshire Police, Health Watch, and other organisations are welcome to join as well. The purpose of the group is to ensure that the development and delivery of the population health management programmes and the JSNA are well managed, and there are some terms of reference that were Annex A for the steering group, which I invite comment on as well. What I thought would be useful is to give a little bit of an overview around what population health management is. I'm sure we're all acutely aware what population health is and public health, but actually what is population health management? There's a slight nuance there. So there's a definition there. It's quite wordy. It's verbatim. It's population health management improves population health by data-driven planning and delivery of care. It includes segmentation, stratification, and impactability modelling to identify at-risk cohorts, and then in turn developing interventions. So what does that mean in practice? So population health management, it improves population health by using that data and really stratifying and segmenting that data to really drill down and identify cohorts of people who are at risk of specific health needs. The image on the right there is kind of the population health management cycle. So we talk about the 3 I's around infrastructure, intelligence, and interventions. So the infrastructure is ultimately what the group is trying to do, is to set up a population health management culture and a population health management approach. The intelligence side of that is that data-driven, segmentation. A massive part of that is the JSNA, and that's why it makes sense for the population health management and the JSNA to work hand in hand. And then the intervention side of that is the actual doing, the actual outputs from what do we do once we've identified these cohorts of individuals. So I go on to say there, following this identification of population groups, it is about designing and targeting interventions. So population health management in York is split into, we've called it enabling, analysing and doing. It could be the 3 I's, but we decided to use sort of more friendly terminology for York. So the enabling part is around supporting the health and care system to use population health data and sort of upskill colleagues around what population health management is as a tool. So there's a core group which consists of colleagues from public health, from business intelligence, and from the CCG, and we meet on a fortnightly basis, and we're really the driving force behind the population health management programme. There's then a monthly steering group which has that wider representation on, and that is around holding us as a core group to task and making sure that we are driving that work forward. The analysing strand is predominantly the JSNA, and that is where myself and my colleague Heather, we're taking the lead on that. I'll speak a little bit more about the JSNA outputs in a second. And then the doing part is the tangible outputs, the real work. So, actually undertaking population health management projects, so we can show the benefit of this approach. And there are various projects that are going on. Some are at earlier phases, some are more established, around specific cohorts within the city. So there's some examples of the work that is going on in each of those strands. Some of those are led by myself, some of those are led by colleagues across other organisations across the CCG. In particular there, around the analysing part, there is around the refresh of the JSNA core processes. So we've done some of that in refreshing how the steering group functions in terms of how we request topic-specific needs assessments from partners, and then the overarching needs assessment as well, the strategic needs assessment is being refreshed. Some of the doing projects there, the one that's probably most established is the diabetes project, population health management diabetes project, which is predominantly being led by colleagues in the CCG, but the intervention's being delivered through the CVS, and we've got really great links in there with colleagues at the CVS. So the JSNA, as part of the Population Health Hub, it's seen as an integral part of the Population Health Hub, and it is an opportunity to capitalise on the membership of both groups, bring all of those partners together, and really ensure that the JSNA is a vital part of service planning, commissioning, and improvement. I think throughout COVID, perhaps, we've all had so much focus on so many other priorities that the JSNA hasn't perhaps had the focus that it maybe once had. So we're really keen to bring back the JSNA to the forefront of people's minds and really bring it front and centre in, like I say, in service planning and commissioning. As I spoke about previously, we've simplified the request form for topic-specific needs assessments, and that was Annex B in the report. That's going to be available online, so people can, not just within the authority, but from across partner organisations, can request these topic-specific needs assessments, or they are available for myself as well. And those requests will be considered at each monthly steering group meeting. In terms of the outputs from the JSNA, I thought it'd be useful to just give a brief history of sort of the outputs since 2013, since it became a statutory duty to have the Health and Wellbeing Board produce a needs assessment. There's the overarching strategic needs assessment, and then, as I said, there's the topic-specific needs assessments. And you can see there that there's been a number of topic-specific needs assessments undertaken under the different strands of the strategy there. So they've been produced over a number of years. Some are due to be refreshed and, are driven by sort of contract and commissioning cycles, and we take those requests. In 2021, there was probably less outputs of topic-specific content because of the impact of COVID and the availability of capacity within the public health team. But two of the topic-specific needs assessments one was around bereavement, which was requested by the Mental Health Partnership, and the second was SEND output. So there's two phases to that. So the first phase was produced, which focused on the age of 0 to 16. There's a second phase that is underway at the moment, which focuses on the sort of 17 to 25 cohort, and that's sort of due for publication in the springtime. Alongside, so that was what was produced in 2021. So for 2022, the planned outputs as it stands at the moment are the pharmaceutical needs assessment, that is due for refresh. That is again a statutory function of the Health and Wellbeing Board to produce the pharmaceutical needs assessment. The original document ran from 2017 to 2021, but because of COVID, it was nationally delayed until March of 2022 and then October of 2022. So we are working with North Yorkshire County Council, as we did previously, to produce two reports across the sort of North Yorkshire and City of York areas The intention is to have a draft out to consultation in July and bring the final report for sign-off to Health and Wellbeing Board in the September meeting prior to its publication in October. The two topic-specific needs assessments that have been undertaken are one around early years with a specific focus on preconception through to 3 years old. The focus is on two key outcome areas identified at the Early Years Improvement Board, which is speech and language communication and social, emotional and mental health. So I'm working closely with Rob Newton and Jodie Farquharson on that, and we've set up a steering group for that. We've had an initial meeting, so we're hoping to publish that later this year, probably around September time. And then, as I spoke about earlier, there's the SEND phase 2, which is underway. One of my colleagues is a good way through producing that, and we've been reporting back to colleagues in education. Again, we're hoping to publish that early springtime. Alongside the topic-specific outputs, there are some sort of engagement outputs as well. So we're hoping to develop a newsletter, a regular newsletter around the outputs from the JSNA. We're hoping to have that produced quarterly. We're also hoping to develop a sounding board where we invite interested parties, members of the public and professionals to give updates on the sort of the content that's been undertaken and request and invite comment on the recommendations that those topic specific needs assessments draw upon. It is also, I'm proposing that I will come back to Health and Wellbeing Board each year to provide updates on the Population Health Hub and the JSNA outputs sort of in the round. However, you know, for example, the pharmaceutical needs assessment, you know, if there's a specific sign off needed from the board, I would obviously come more frequently than that. The final thing that I want to discuss is the strategic needs assessment and how that impacts on the Health and Wellbeing Board strategy. I know Peter and Tracy are discussing that shortly around the refresh of the Health and Wellbeing Board strategy. And I just wanted to make the board aware that the overarching strategic JSNA is available online at Health York. We're currently refreshing the narrative on there, but the data is presented under the headings of starting and growing well, living and working well, aging well, mental health and place, as you know. So the first phase of that is refreshing the narrative, making sure that the data and the content is up to date. That is almost finished. We've just been having some technical difficulties with the actual website, getting the information on there. But then the sort of the medium-term plan, so for the summertime, is to look at that website as a whole and, you know, see if we can bring it a little bit more, make it a little bit more user-friendly, a little bit more engaging. You know, that has been the same website for a number of years now. So we looking at what some of our colleagues in other authority areas are doing, I think we could be more innovative with that and more engaging with that. So I'm hopeful that that will be a useful resource for the boards as you develop your new strategy. And I just wanted to give some, for those that don't know, this is the Health York website as it stands at the moment. So, you know, this is just the section on aging well. So, you know, it's got some narrative, it's got some graphs in there, it has the supporting data, but I just feel like we could do a little bit more around the imagery, around how accessible that is and how engaging that is for members of the public and interested professionals to engage with. There's another example there of the introduction section and the sort of the tiles and the different sections of the JSNA. That is everything from me.
Just before I ask for questions, I think you'd find, Phil, that if you wanted users to comment on it, I'm sure Sian would pull a small group together to have a look at it and tell you what they think of it and whether they think it's intelligible or not as relevant as it should be. Yeah. So don't forget to ask Sian if you want. Right, Peter,
well, thank you.
You first. Thank you.
Chair, can I just check I can be heard?
Yes.
Brilliant. I did the enormously clever thing of leaning on my mute button, so apologies. I was talking previously, but don't think I was heard. So just I really welcome this from Phil, and thanks, Phil, for taking us through this. Just this really does, I think, the board members really join with the next item on the health and wellbeing strategy, and just thinking about York's population, which is changing. We know that COVID has affected many aspects of health in York beyond sort of direct infection in quite a large way. We know that this year we're going to get some updated baseline data from the census that was taken last year, which is probably going to show quite a large change, for instance, in the ethnic mix of our population, some of the demographics. We know that student numbers have been increasing. We know that health issues have been changing, and lockdown habits have probably increased the number of people who are sort of living with long-term conditions. So there's a lot of change. And for the purposes of the health and wellbeing strategy that we're about to commence, I think we take all of our professional opinions and expertise into that piece of work. We take the voice of the citizen, the public, into that work. And the third thing is what the data says on population health need. If we neglect out any of those three, we've missed a key chunk. And so I'd like that website that Phil showed us. For me, it's not really a novel to read. It's an encyclopedia to constantly come back to as we think about our service changes, the strategies we want to be writing. So we will endeavour to make it as accessible and helpful as possible. Please do give us feedback on that, and let's, I guess, as a board and as a community, endeavour to keep on returning to what it might be telling us. And if we needed to tell us other things, topic specific deep dive needs assessments on bits of the community, let's put those pieces of work in so we can really understand this sort of stuff better. But really welcome the report, and thanks, Phil, for the summary.
Yes, let me join in those thanks. Now I've got Emma, Ian, and then Lisa. Emma first.
Thank you. Yes, so yet another welcoming of that report. It's obviously something we work quite closely at the York Healthcare Collaborative. So myself and Becky Field represent the 5 PCNs in Central York, who obviously are targeted with improving population health from a delivery perspective in primary care. So yes, Phil, I think the ask you were saying about updates, I guess for us, it's as much as possible. We have many sources of data that we're receiving, but if there are updates, I guess it's just saying, I know Peter does bring a lot of them to us through YHCC, but I guess it's just that prompt as guardians of the delivery element of the population health targets. I guess it's what's topical, what's new, what do we need to know about, because clearly we're keen to help with the delivery part. I know you touched on your report about their change to the primary care contract, the PCN contract. So you mentioned about IIF. Well, we love 3-letter acronyms in health. There's been obviously on one hand, in a disappointing way, primary care has done an awful lot of work. We got a lot of these INIF, these targets, which were population health targets. So just to give some examples, they were about gathering ethnicity data. They were about trying to get hypertension rates up. They were about SMI health checks, learning disability health checks. So they had a lot of really good targets. Then, of course, we were told, suspend everything, put everybody on the vaccination hubs, which of course we did because it was a national effort. But then, of course, these have been suspended. So in some respects, a lot of the really good work that's gone on this year is not going to get necessarily highlighted. But I do hope through your Population Health Hub, we'll get to see what progress is made, but also to learn about what's worked and what hasn't worked. Because I think with a lot of these initiatives, there is learning, so we can identify a problem, and I guess I think the joining up element is having that population health hub feeding into, say, the provider organisation like the York Healthcare Collaborative, in which we can then discuss how can we, across all the different agencies, try to deliver these targets, and where are the barriers, and how we might overcome them, and to all achieve that same goal. So I guess it's welcoming the report, but also about the joining up element. And Phil, I guess it's just trying to find a way that when new updates come through and when new reports come through, just to make sure they get shared so that those who are involved in the delivery element of the health part can do their bit. Thank you.
Thank you, Emma. Ian, next.
Yeah, very briefly. Thank you, Chair. Welcome this report. It'll be really interesting to see the development of the various needs assessment components that are going to make up the JSNA over the course of time. Just to say that the Early Years Improvement Board this morning didn't have a clear timetable for the collection and analysis of its own contribution to that, but I'll make sure that it's done in time for a report to this board in September. And I just want to make sure that Phil has got the time his timescale adjusted to have it prepared, his JSNA contribution prepared and ready for that date as well. Thank you.
Thank you. Lisa.
Thank you, Chair. And again, another very welcome report. And thank you for the involvement of North Yorkshire Police in this work. I suppose the comment from me is that we deal in a very reactive way in policing often to many of the issues that are identified in this JSNA, but we are very keen to support very much a prevention and early intervention aspect of this work through the hub, because of course preventing harm is much better than cure in all walks of life. So I'm really keen to see this developed in a prevention of harm way, as opposed to just, quite rightly, there are some very important reactive services, but I think we'd all like to see the focus being on prevention. Thank you.
Thank you, Lisa. I think we'd all be with you on that. To conclude, Phil, are there any last comments you'd like to make?
I don't think so, no. Other than, I guess, as the board, are you happy with the proposal of coming back annually, unless there's an exception to that?
Yes, that is
update?
the question. Yes. Do we want to hear more frequently, or is annually okay for everyone? Can somebody express an opinion? Nobody. Oh, right. Anne wants to express an opinion, and then Lisa possibly. Is her hand still up?
Yeah, no, thank you. I think annually to hear would be really good, but I think there are, when you say for bespoke things, so once we've got the children's subgroup running, then actually we need to be, you know, clear that we're really connected with you about that, so that we can feed in properly, really.
Thank you. I'm sure that's right. Lisa?
Thank you, Chair. And I think as a substantial agenda item, it would be annually would be fine, because I think there'll be information reported into other boards that are connected into this. So it would be nice to see those updates in the other board updates that are coming to this meeting, that it gets a mention or relevant inputs are in those other reports and those other board updates. But as a substantive item in the round at this meeting annually, I think would be acceptable.
Thank you. And Peter?
And just to say, as well as an annual sort of report, Phil mentioned a newsletter which will come out quarterly to let people know what JSNA products have recently been raised. So that is helpful. I appreciate many on this call probably get hundreds of emails every day, but being able to open those and just have a quick squiz through and anything takes your interest may fill that gap in terms of a knowledge of what we're on with.
Yes, that will go out to all members of the Health and Wellbeing Board, Peter, won't it?
It certainly will.
Good. Lisa, is that an old hand? It is. Right, well, everybody's noted the comment. Everybody's commented that wants to comment. And we've talked about the keeping the board informed. So I think we can wrap that one up. And thank you very much, Phil, for the work you've done on it, and keep on with the good work. So the next item is on page 29, and this is the renewal of the Joint Health and Wellbeing Strategy. And I think, is it Peter and Tracy? Peter, are you starting with this one?
I am, Chair. Can I just check again, you can hear me?
Yes, we can. Thank you.
Lovely. I am, Chair, yes. Just to cover this paper on the renewal of the Health and Wellbeing Strategy, the board has a number of statutory duties, which people are probably aware of, one of which is the production of a Health and Wellbeing Board strategy. Our current one runs until 2022. We didn't name a month, but I guess we can say that during the course of this year, it does need to be renewed, and it's been there for 5 years. People will probably be aware of the approach that we've taken following the sort of seminal work of Michael Marmot and the emphasis on a life course approach to improving health. Recognizing that people generally accumulate either the things that make them healthier or lead to ill health across the course of life. We wanted last time around to start by emphasizing giving every child the best start in life, moving on to the working age population, those who are older, and then thinking specifically around mental health. That was the approach we took last time. We need to renew it this time in a world which has changed. And I think the thing I would highlight for board members, which we're all aware of, is that one of the key contributors to the health and wellbeing strategy, in fact, the other member of the board who has a statutory duty to be a part of it, is the clinical commissioning group. And as of July this year, the clinical commissioning group won't exist in York, and we will have the integrated care system. And I think that brings opportunities and probably extra complexity about how we write this health and wellbeing board strategy, because the integrated care system are obviously covering quite a large population and 6 local authority areas, and we are covering just the City of York area. So I think we have to bear in mind as we write a new strategy that this will sit within a system in which there will be some of the same partners around the table in terms of the makeup of our police partners, our voluntary sector, our GP practices, but other partners within health who have changed some of their structures and arrangements and will be producing their own strategies. One of the key things I think this strategy will do is that it itself needs to be taken into consideration by the ICS when the ICS writes its strategy for the system. And actually, if we don't have a strong sense of what we're about here in York, what we want to change for our population, how we want to improve, then we can't expect the ICS, when it spends quite a lot of money on health and care in York, to really do that in a way that works. So actually, I think we need to, and never more than before, get this right and have a very strong strategy in place that really articulates what we're trying to do. So the paper just sets out a number of things that we will do across this year. We'd like to do it in the first half of this year. We need to align it with the ICS's writing of strategy from a health perspective, but from a city perspective, thinking much broader than health, we are also as partners writing a 10-year strategic framework for the city, a sort of post-COVID plan that won't go into huge detail about individual services, but will cast a vision for the City of York. And health and wellbeing is already planned to be a big plank of that. And essentially, we're being asked to write the health and wellbeing bit of that broader 10-year strategy. So we need to align to that as well. Lots of our other partners will have their own strategic frameworks we need to take into account. And I think we also have to be aware that there's lots of work that goes on an ongoing basis to engage York residents in co-producing health, in getting their voice into healthcare services. The work of Health Watch has been ongoing. The work that our voluntary sector do is ongoing. And whilst we definitely want to make sure citizen voice is included in this work, I think we also have to recognise that there's lots of things that have happened that we can capitalise on and we can make sure we're mindful of. I'd throw into that, I mentioned earlier on that the Multiple Complex Needs Network sponsored a piece of work on cultural values and what are the values we hold as partners within the system. I think it would be foolish to ignore that, actually taking that insight into this work. I know there's an enormous amount of co-production work around mental health transformation that has happened. Again, we'd probably be foolish to replace or duplicate that. Actually, we should take that learning into this. So there will be bits of this where we feel perhaps we need to make sure we go out again to ask those sorts of questions of our population, and other bits where we probably need to take into account what we already know. And of course, as already covered today, the work of the JSNA, which is a plank within this. So the paper is asking board to approve the kickoff of a strategy writing process, but then to comment on how they would like that process to commence. We've not started anything yet, so everything is up for grabs. We can shape in this meeting how we'd like that to proceed, and then we can go away and start the conversations about how we do that. Start writing the strategy for a draft to be coming back in the summer of this year to be commented on further by the board. It will need a public consultation, and then it will need to be published formally later this year. So it's probably all I wanted to to say, Chair, on this, and just happy to get some comments and the discussion going.
Tracy, can I bring you in next? We do have a suggestion of a workshop. Is that still on the cards?
Yes, we can pull together a workshop where the Health and Wellbeing Board can sort of give ideas, contribute. So yes, I can pull that together and we can look at what the best time to do that would be if that's the approach you would like to take.
Yeah, that's lovely. Thank you. I've got Michael and then David.
Thank you very much. Really welcome kicking off the new strategy. Really important, really exciting piece of work which you can do in terms of shaping what the city may become over the next 10 years. Absolutely fantastic. I guess the thoughts which are occurring to me are that when we've talked before about the population health management approaches and the JSNA, I guess that will throw up some of the things that we know and that we suspect that York is still a very unequal place, and that inequalities is one of the key things which we would hope to tackle over the next decade. And so I guess my kind of contribution to this debate is that as we develop our approach to the strategy, we think certainly about the life course and the accumulation of things which help people stay healthy or adversely affect their well-being, that we overlay that with a thought about inequality and what drives inequality in York and what actually tackles it, and we build that into the strategy as we go forward.
Yes, thank you, Michael. And that would include getting information from groups like the Financial Inclusion Steering Group, because it spreads way outside the health remit, doesn't it? It looks more at the determinants of health as well.
Yeah, absolutely. I'm sure
yeah.
public health will no doubt keep telling us that, and we'll keep trying to do something about it.
Thank you. David and then Janet.
Thanks again. And I've realised that when I spoke earlier, I should have said who I am, since I'm substituting for Alison Simmons, who normally attends. I chair the trustees of York Centre for Voluntary Service, and I'm on the Health Watch steering group. I think I'm taking this opportunity of being here to mention that last year, when the York CVS decided that it was time to review our strategic plan and to look ahead at the next 5, potentially 10 years, we had a series of discussion groups which were extremely helpful in helping us to focus on the social aspects of our role. Because clearly we're here to support volunteering in all its forms, but we're also a social welfare organisation. And 2 particular themes I wanted to pick out from that. One actually reflects on the comments that Michael made a moment ago, which is to do with poverty. And we wanted to take a particular focus on the causes of poverty. There is a great deal of good work goes on in York to alleviate the symptoms of poverty. And of course, we've seen the work of food banks in general, but during the pandemic, they've been vital to many people. We want to go back into what is it that causes poverty in the first place, and what more could we collectively in York do to tackle those causes. So we are now in a position to move ahead this year with a Poverty Truth Commission. There have been Poverty Truth Commissions in other parts of the country previously, which have helped bring together people with lived experience of poverty and those who are in a position to take decisions that affect their lives. And those 2 sets of commissioners work together to form ideas as to how things could be done differently at the local level. Then they don't have the capacity to change decisions that are only taken nationally, such as the rate for universal credit. But clearly there are things which can be done to tackle the causes of poverty at this level of the City of York. So I think the Poverty Truth Commission will link effectively with the planning for health and well-being in the future, and with a similarly long lead time in terms of tackling some of the issues. The other major issue that came up far more strongly than I might have predicted was loneliness, and linked with that, social exclusion. Now, they're not synonyms. You can be socially excluded and not lonely, and vice versa. And it was what came across so clearly was that loneliness especially is something that the city has discussed many times, though Health Watch published a report in 2014 on it. There was a Red Cross initiative supported by the Co-op. And today, there are many actions that are working to help people who are experiencing loneliness. And I would single out social prescribing as a massive success story so far, but which helps to demonstrate just how much more there needs to be to support people who are experiencing loneliness. In previous iterations of our work as in health and well-being here, there has been a tendency to look at loneliness as being a matter for older people. And certainly aging well, it has a really important element there. Age UK and many others do excellent work to try to overcome this. St. Sampson's Centre, that, you know, I'm not going to list them all because there are lots of organisations working to support people experiencing loneliness in later life. But all the work that's done at a national level by the Joe Cox Foundation, and indeed in what appears to be a now forgotten national government strategy published when Theresa May was Prime Minister, there is this sense that loneliness is something that affects a very large part of the population, not all at the same time, but many people experience loneliness a lot of the time, and that can be triggered by changes in their life. So whether it's a transition from school to work or university, transition between jobs, moving to a new city, having children, divorce, all of these things can help or promote a sense of loneliness. And equally, we know that loneliness can prefigure ill health, both physical and mental, and that it works the other way around. Experiencing mental or physical ill health can increase the likelihood that you're going to be lonely. So I'm using this opportunity to make the plea that when we look ahead at our 10-year horizon, that in addition to the things that are explicitly mentioned in today's report to do with the high-level principle of reducing gaps in life expectancy and healthy life expectancy in populations across the city, we really look at what we mean by well-being and take account of some of the real issues, such as loneliness, that came across so strongly in our own strategic review, that I really feel that it's something that has a profound public health impact, which we should be taking into account as we look ahead over the next 10 years. Apologies for speaking at such length, Councillor Runciman, but I hope it's been useful.
Thank you, David. Yes, a couple of points from me before I go to Janet. The Poverty Truth Commission is on the agenda for the March meeting. So perhaps you can talk to Alison about whether you've said sufficient or whether she still wants it on the agenda. The issue of loneliness, the last time I looked at the data for loneliness, the greatest loneliness was actually among young people. And whether that was because of the shutdown, because of COVID, I don't know. But I can say from experience, if you're at home with a very small baby that doesn't actually say very much to you, you can be extremely lonely. And that will be something that will go for other situations as well. Mercifully, they grow up and then they do talk to you, and it's wonderful. Thank you, Janet. Do you want to make a comment?
Yes, I would like to pick up on that one. Because interestingly enough, I think, Carol, the point at which I was really lonely was moving to York as a young mum with a very small child and pregnant with the next one, and a husband who dashed off to work long hours away from home and not knowing a soul and not knowing how to get to know people. It is very challenging, and you can feel desperately isolated in your 20s. I worked very hard at it, and eventually here we are. But I think there are such widespread issues around loneliness, and some of it goes back to care in the community. I mean, you can be looked after in the community, but sometimes it's very difficult to make those social connections, which in a way, living in some sort of community setting at least gives you those connections. So I think it's a challenge, and I think it is very important that we always remember it as a huge factor in one's emotional well-being. But I also wanted to pick up on Peter's point. I think it is terribly challenging for York going forward into the new health environment, that we do carve out and maintain a very distinctive sense of our position. We are in a very, very special place within this huge, appallingly disparate health economy. And York can get just washed over to a certain extent by rural life and all the other things. And we're not Hull. I mean, Hull's there, but we're not Hull. We're very different from Hull. So I think it is terribly important that we have in that strategy. And I'm no good at doing strategies. I'm not offering to help at all. But it's very important that we do establish what it is and why York is different without being horrid about it. But we do need to have that very clear cultural stamp so that people recognise it and see it as something concrete and useful and valuable, because we can offer some really very interesting ideas and inspiration. So those two elements, yes, thank you.
Thank you, Janet. I'm going to take Anne as the last comment on that, and then Peter, if you want to make a brief comment or not, and then we shall move on to the next item, which is going to be you again anyway. Anne.
I was just thinking, what an incredibly profound moment when you think about the impact of loneliness that is ageless, actually. And probably for the first time in our country, we are talking about children experiencing loneliness, and actually the opportunity to make a difference in that for this generation to come and prevent that long-term enduring mental health problem. So I think that was an incredibly great interjection, David. Really good to see this board really understand. You know, my heart goes to, of course, I'm a statutory DCS children, and my heart goes to the profound experience that some of our care experienced young people had over the pandemic. And actually all that's done for, certainly for me, and good to be in good company today, is it's just made me more passionate about being able to sort something like that. We've got a real generational opportunity to resolve some of that long-term enduring, really serious stuff. Yeah.
Yes, thank you, Anne. Huge pressure on carers and much isolation and loneliness during the lockdown. You're quite right. Yearly assurances, as it's a 10-year plan, are we happy with this coming back annually to make sure that we know something's happening? Yeah. Yes, I think we are. Good, thank you. That's good. That's a very useful discussion. Now, our final item, which is preventing harm and supporting recovery for those using drugs and alcohol in York. And Peter, you're introducing this.
Thanks, Chair. So this paper is a combination of a couple of things, which I'll take in turn, if that's okay. They link very closely, but they are discrete, and I want to make sure that within the conversation we're able to sort of cover both. The first is that drugs and alcohol as population health issues probably deserve a sort of health and wellbeing board hearing after maybe a little bit of time at which they haven't, particularly as there is a new national strategy. And so what the paper does is to just lay out, first of all, some of the impacts of both illegal illicit substances and alcohol on population health. It starts off at from point 6 talking about the impact of alcohol in York, and unlike some other health indicators for our city, we're blessed in being a fairly affluent city overall with some good health outcomes. That isn't the case if we talk about the situation around alcohol in York, and for a number of years alcohol has been of concern from a public health perspective. And that's not simply one aspect of alcohol. Our minds could potentially, if we let them, be focused on what we see as to be excessive drinking in the city centre of York on a Saturday night. That's a problem, but it's not the only problem. In fact, I think it really falls part of a pathway where we see from the availability of alcohol in terms of the number of licensed premises, when we see our alcohol harm when it comes to people's reported average drinking levels, which is generally more at home than outside the home. When we looked at some of the data from lockdown in terms of consumption, and then we follow that through to people consulting their general practitioner for alcohol use and people's admissions to hospital, both directly due to alcohol, trauma, injury, that sort of thing, but also the things we know to be attributable to overconsumption of alcohol. I think we're now on perhaps 7 or 8 types of cancer, which we know can be attributable to alcohol overuse. We know that cardiovascular disease, alcohol has a role within dementias of different types and within diabetes. And we know that alcohol has a significant impact on people's mental health. And we know in York, on either of those measures, the very direct impacts or the very broad impacts, our hospital admission rates are higher than other areas and are something of a red flag for us. And then sadly, we do know that a number of people every year die directly attributable to alcohol and indirectly attributable to conditions arising from alcohol use. So the paper talks about the impact of alcohol and talks about then the impact of drugs and substances in York. In York, we have, like anywhere, a cohort of people who have various levels of addictions, which is quite varying, and the substances that are used are varying, and the amount of people who receive support and treatment is probably a huge underestimate of the amount of people who are using substances. Substances will have varying harms on the body. They will come into different classes, as I'm sure people were aware, in terms of what the criminal justice system would see. And then obviously there are different elements of drug use in terms of the possession, the supply, and the use of drugs. But thinking just in terms of health terms, we know, for instance, that the number of people dependent on heroin and crack cocaine, which are our 2 largest cohorts of people in York and nationally, has been rising. We know that what would used to be known as legal highs, and we're sort of better to talk about novel psychoactive substances. Those substances have been used increasingly, particularly with children and young people. We know drug-related deaths in England and, in fact, in the UK have risen year on year for more than a decade now. And sadly, we do see it sort of in the low tens of people every year in York dying directly as a result of overdose or a result of a drug being very closely linked within their death. We know amongst children and young people that drug use is increasing. School surveys have suggested that. They've also suggested that the role of parental alcohol and drug use in terms of children who are looked after, or children who are within the social care system, children in need, children whose cases are reviewed through serious case reviews, and we can look nationally at those. But alcohol and drugs are increasing as factors identified within those views and for those children. And so the paper sort of articulates substances as a population health problem. And it then goes on to talk about what's emerged recently, which is a new national 10-year drug strategy. It does mention alcohol, but it majors on substances. And I think that's one of the things I think the board may want to consider as we discuss this, is how we can make sure that some national agendas which potentially go towards more work and more funding within the substance use area, which is crucial. We can make sure we reflect on York's particular need where alcohol is concerned, and not forget about alcohol as we implement the new work. The plan, the national plan, is broad-based. It has 3 key aims: breaking drug supply chains, delivering a world-class treatment and recovery system, and achieving a generational shift in demand for drugs. And every bit of that will impact pretty much every agency in York, whether it's the university, whether it's our businesses, whether our schools, certainly police, probation, our prison system, and obviously the council and the NHS. The good news is that there is quite a lot of funding attached for local areas that has been taken out, probably it's fair to say, from the system, which is being put back into the system through this new national strategy. And actually, we think probably spending for the York population around drugs and alcohol, particularly treatment and recovery, is likely to rise by about 40%, which puts it probably back to where it was at the start of the 2010s. And that has to be used on a variety of things. At the moment, we're in that strange interim period between having a national strategy and being given discrete details on how much money there is new for York and what the conditions on the use of that money are. But we had a little bit of extra money last year with conditions attached. And so the paper outlines a little bit of what we spent that money on, particularly looking at schemes like liaison and diversion from custody and from prisons, the treatment on arrest type schemes where instead of people being given a criminal justice disposal, they are diverted and directed into the treatment system for help either with alcohol substances, and in fact that can be a court disposal as well. So instead of handing down a custodial sentence or an order, a court can make that type of end. So the national strategy has lots of things that we will be able to use this money for. A large amount of that will be restoring the amount of people we're able to treat for their substance misuse harm. And over the last years, the thresholds to be able to be treated have increased as the years have gone by, because that budget has had to be rationalised. And I think as that goes through, we will be able to see a larger number of people, which I think is good news for the system. The last element of the paper, and then I'll let people come in for comments. I'm aware I've been talking for a while, is to talk about the overlap between substance misuse, alcohol, and mental health. And if we're talking about a particular group of people anywhere in the country, really, and of course in York, who the evidence shows really have really poor outcomes, but also don't always receive the best, highest quality of services, and see the services join up in the best way, would be people who have both an addiction issue and a mental health issue. We refer to this as dual diagnosis, and we know that often there are barriers to getting the right mental health treatment that you might otherwise get because an addiction either stops the engagement or stops eligibility for a service. And that will work the other way as well, that addiction treatment services often may have barriers in for those who have mental health issues to be able to get the right treatment for their addiction and the detoxification or the substitution therapy that it might need. So in North Yorkshire and York, together with our North Yorkshire partners, the close involvement of TUV, close involvement of primary care, and all of the treatment and prevention services delivered by Changing Lives, Humankind, Spectrum providers who work in this area. We've written a dual diagnosis pledge, which is attached to Annex A. And I guess this is a statement of intent from the system to say, we know we don't do as well for those who suffer from dual diagnosis as we could. Let's do better. Let's pledge a number of cultural changes about these services that we are running. Let's pledge to not ask which came first, the addiction or the mental health issue, but we treat the person as a person. Let's communicate better. Let's make sure we train our practitioners in mental health on addiction issues and our practitioners in addiction services on mental health issues. And let's make sure that we are working better for this group of people. The request of the board is both to discuss this issue, to take note of the strategy nationally, but also crucially to say if they're willing to sign the dual diagnosis pledge, which will go onto the website that's been set up that the board has signed it, will show our commitment. And then I guess it's for organisations around the board to take that away and make sure they're taking due regard of having signed that pledge for their organisations and the different bits that they're involved in. So that's an overview of the paper, and welcome comments and discussion, Chair.
Thank you, Peter. I've got a couple of comments on the pledge, which I'll bring up later, but I'm sure people will have comments on the paper in general, especially when we start looking at the data. Naomi, would you like to go first?
Yes, thank you, Chair. I have several comments. I could talk for a very long time about this particular issue, in that I started my career in substance misuse as well. It's something I'm very passionate about. So I think there's a number of issues that I would probably raise. One is obviously support for the pledge. We started working with Dolly Cook in Changing Lives back in 2019. And we've got psychology input to that to take that forward. And I think that's been successful in getting us to a certain point. I think it's about changing custom and practice, at a service level, and we know that. So it is not an exclusion criteria, but we know in reality, the ability of people to engage therapeutically is diminished. And so what we need is to promote that joint working in parallel with one another to make sure we get people to that stage as quickly as possible as part of their recovery. I think from a trust-wide perspective, in terms of the development of the strategy, we have had conversations about this and the opportunity that this gives us really, to look at how we develop and support our staff in working with dual diagnosis and substance misuse. There are some key challenges, I think, for mental health providers in the strategy, although that's very welcome. And so we need to look at how we do that and support across both areas of service delivery. So I think that's really welcome. And I think there's a real opportunity for closer work with other partners, substance misuse and alcohol in particular. I think there's always a risk that alcohol is overshadowed by substance misuse because of the criminal implications, but we know that the harm that does to families and to our communities is significant. So that's something I think we need to be kind of mindful of when we pick up the actions really from this. On a locality basis, we're going to continue with the pledge and trying to get that culture change across our services and embed that joint work. And I think from a population health perspective, one of the questions I do have, and it's helpful to see some of the statistics in the paper, is just how do we know how and where we benchmark against other cities, for example, with the impact of the student population and the tourism into the local area, and what that tells us about strategies to address alcohol and the harms that gives, and also perhaps what we can do to influence and reduce the national legislative barriers, particularly around alcohol, so that we could, take a more focused local action around some of the pricing and marketing availability in York.
Yes, thank you, Naomi. I've got Michael, Janet and Emma. Michael first.
Thanks very much. Really, really interesting paper. I think on the pledge, I think it's really, really important that we sign up to it. But I'd say more important that we hold ourselves to the pledge, hold the services that we are responsible for and one another to the implementation of it. And where things aren't right, we say it, we call it out, and we refer back to it. Because it has been an issue. I also had a background in substance misuse services, and it's clearly been an issue for a very, very long time. And I'm glad that we're signing up to resolving it and pledging to do that. In terms of the strategy, when I had a look at the strategy, I'm really interested in the part around integration, which talks about, I think, again, some of the more wider determinants around substance misuse. And I think in terms of developing a local approach to that, locating that within communities, thinking about how employment opportunities, how good accommodation, how the ability to build a good life, thinking back to some of the comments previously about inequalities, that those are the things which in York we should be able to do. So as well as doing the more formal treatment, my ask would be that we really focus on those other elements as well.
Yes, thank you, Michael. Janet's next.
Thank you, Chair. I wanted to pick up on the alcohol issue, because I think it is important that we recognise, although for obvious historic reasons, alcohol has not been deemed a dangerous drug, partly because the medieval monks were drinking it in great copious amounts to stop them poisoning themselves with contaminated water. So it remains an accepted form, but it is, and I think, quite frankly, I think some of the social consequences of an excessive addiction to alcohol are much more difficult to deal with than some of the consequences of people who are taking perhaps the drugs that are within the criminal justice system. The social impacts, the family impacts, the employment impacts of people who are profoundly addicted to alcohol are huge, and we see that. And it's not just the stag parties and the hen parties, it's the strange rows you get in the corner of streets where three people just can't control themselves and are letting off steam and causing, in the end, can cause quite significant damage to each other. So I would like to feel that within this strategy, we can put alcohol very high within it, as far as the rules and the everything else allow, because I think we do have to recognise that it is a very significant issue in York, and the hospitals see the consequences of excessive use of alcohol daily, hourly, in attendances at accident and emergency. You see it with the result of the way people respond to health professionals. It has a huge impact across society, and therefore I think we have to really take it on board as a significant element of our strategy. And yes, the dual pledge is hugely important. Sometimes you can't tell which came first, the excess or the mental health issues, and just fixating on one and not the other is not helpful. So I do welcome this strategy, but I do hope we do put the alcohol issue really very much at the heart of what we're doing.
Thank you. I've got Sian, Emma, and then Anne, and then I shall probably conclude. Sian.
Thanks, Chair. I just wanted to say, like other people, I have a bit of a history around working. I did some work back in Middlesbrough a very long time ago with a drug forum who were very keen to have lots and lots of conversations about dual diagnosis, and raised significant concerns about the fact that everyone was interested in which one you had to fix first. And they didn't want to separate out elements of their life or even talk about being fixed. They just wanted someone to help them with the issues they were experiencing without judgment and stigma. And I suppose for me, it's a little disheartening that actually it feels like we haven't moved that far forward with the discussions about dual diagnosis. We're still asking people to pick something they want to work on rather than providing support for all aspects of the things that they're going through. So I think it's really good that we've got this pledge. I'm very keen on that. Like Michael, I share the concerns about it's fine signing up to a pledge, but how do we make sure that actually that means something? I know we have, as a Health and Wellbeing Board, committed to a number of different initiatives around being a very friendly city to a variety of different groups, but how do we embed that within our health and wellbeing strategy, within every decision that we make as a council or as a health body? How do we make sure all of that stuff stays central to who we are and what we do? So I think that would be my question about that. I think it was quite interesting that our main concern about the Trieste model was that it didn't tackle the issues of dual diagnosis. It didn't provide support for people. And I think it also doesn't acknowledge the self-medication elements around if you have a particular, I'm trying to think, so if you are neurodivergent, potentially, how are you using drugs and alcohol to try and normalize your behavior? And I don't like the term normal because I'm not convinced that I know anyone who is or would want to be normal. But there is so much stuff in there around that. And I still think we don't acknowledge that enough. We don't acknowledge the impact of societal pressures on people who, diverge from what we accept collectively. I don't think we think enough about the pressure that puts on people and the potential impact of drug and alcohol use there. So I think it's really good that we've got this, but what else are we going to do, and how do we embed it, and how do we sort of weave it as a strand that underpins everything? That would be my concern and my question about it.
Thank you. I'm sure Peter's taken a note of that one. Emma, you're next, and then Anne finally.
Gosh, Peter, you've got a very supportive board here. So my background also was a specialist GP working in drug and alcohol services. So like Naomi, Sean, Michael, all of us are pretty passionate about this, which is great, because I think it's the only way we're going to affect change. I think probably of all the things you've said, totally sign up to the pledge. Ring fencing of funding is absolutely needed, because our drug using community is obviously has massive implications and costs, but also are the least likely to advocate for their health needs. Sean, I doubt you've got many going to your Health Watch meetings. They don't access healthcare apart from in desperation, and they're well known to the criminal justice system. They need a different approach. And sadly, something I've campaigned a lot over the years about is every cut ends up being to the drug budget. And there's a lack of, I fear, of appreciation of why people use drugs. If you don't get to the why, you cannot move this group forward. And we've talked earlier about the children's strategy and an appreciation of the toxic triad. If you grow up in deprivation with drug and alcohol problems in your family, along with mental health and domestic violence, your opportunities and chances on life are markedly impaired. And therefore, drugs may well be the thing you turn to cope with the trauma and the harm that's happened in your life. And in my experience of working in the York Drug and Alcohol Services, that goes for the majority. So these are very damaged people who've had very difficult lives. And I think they, as a Health and Wellbeing Board, I hope we are absolutely committed to trying to support this group, because they will not advocate for themselves. So I think we have to advocate for them. And so ring fencing funding and support in the long term is absolutely needed. It was very disheartening to see that York was at the very bottom of drug-related deaths. I know we have small numbers, but it was also because it's very hard to cater for a small, very complex need group. Ironically, in larger cities where you have bigger drug problems, of course, you've got more resources. In York, we don't have a lot to offer. So we have a very small niche group that engage with changing lives service, and I think more is needed. The implications of some of the cuts as well have been to the lack of residential places. So when you're looking at alternatives to the criminal justice system, for groups of patients who are in a very chaotic, very difficult position with a lot of social stresses around them, actually residential placements are sometimes needed. At the moment, we rely almost on the criminal justice system at times to keep people safe, and that's not the right approach to my mind. So I guess I'm welcoming a lot of aspects of this report, and the commitment, Peter, it's so welcome that there's some long-term ring-fence funding coming towards this area, because we will not get better without that. So I would personally like to say we have to separate drug and alcohol. Alcohol is a very acceptable drug. It has a different cohort of users to those who go down the drug use. There is, of course, some overlap, but I think an alcohol strategy has to be very different to our drug strategy. I welcome the report about minimum pricing of a minimum unit of alcohol. It's got the biggest evidence of anything we can do in alcohol. So again, I would very much welcome our York Health and Wellbeing Board supporting the 50p per unit, sort of a national campaign. Whether we can deliver it locally is another matter, but supporting that would be a really strong commitment going forward. And yes, so Peter, complete support for the dual diagnosis work, and I'm glad that we're sort of moving this forward. And you've got a really passionate group here on the Health and Wellbeing that all want to make, support this vulnerable community. Thank you.
Thanks, Emma. I could write to the appropriate minister on behalf of the Health and Wellbeing Board, saying we support minimum unit pricing if that was what the Health and Wellbeing Board would like me to do. Some nods and some yes, thank you. Right, Anne, you're the last person to speak.
Yeah, no, thank you, Councillor Runciman. Peter, you have my unrelenting support in relation to all of this. And I think some of the things, I guess, feedback-wise, I think it would be helpful to have somewhere in here a bit of a statement about exploitation of children, because we know, for it to be stronger, really, because we know that the significant number of children who are exploited, it starts with, it's manifested through addiction, and through that kind of supply of drug use to children as young as 10, 11 and 12. And then when you get them in the system, their trajectory for the rest of their life is really, really quite difficult. I guess there was a couple of points I want to just, because early in the agenda, we talked about children, and so it feels appropriate to kind of end quite strongly on that. It's really important for the Health and Wellbeing Board to understand that the majority of children that we go into care proceedings, so a really serious intervention in a child and family's life, where we make the most ultimate statutory intervention for them, involves drugs and alcohol in York. It's a very high percentage in comparison to elsewhere. It's also a really strong feature in our children who are subject to child protection plans. So I think it's a really live and kicking issue. It's a phenomenally expensive process when we're in court proceedings and we have to commission very specialist assessments. And also for the small number but significant number of young mums who are caught in that trap of addiction, where actually they may lose multiple birth children through having to be in care in order to keep babies safe. So it's great to be here and to be able to influence some of that, and it has to be one of the key priority areas in this subgroup for children.
Good, thank you very much, Anne. Made some very important points. Peter, I've just got a couple of questions about the Better Together paper. If you've got it in front of you, where you're talking about ensuring people are considered throughout and have a voice, can I ask if advocacy is used sometimes?
Chair, it absolutely is. I mean, I think particularly in York, actually, we are blessed in having a very peer support based approach to both drugs and alcohol as issues, and the York in Recovery community is sort of gets national plaudits in terms of some of the ways it involves those in recovery in the active ongoing work of recovery, recovery-led model. Obviously, there's a number of people who haven't been through treatment and recovery who won't access that. So, we're always looking to try and increase the scope of that. Specifically around dual diagnosis, there has been, this is a North Yorkshire and York pledge, not just a York pledge, and I know it's a number of years in gestation, as Naomi sort of pointed to. So along the way, there has been that patient sort of voice within it, and I think that will need to be maintained as we go. It's in a way an answer to Michael's question, which was, how do we make sure that this is actually working itself out in reality and in culture? Well, we set up systems where people can make it very clear as soon as it's not working out that way, so that we can surface those issues and start to deal with them. And to do that, you have to sometimes work harder with certain communities than you do with others, and particularly for this community, I think every effort needs to be made. So I think the answer is yes, Chair, in terms of advocacy, but I think we want to keep on doing that.
One more point. Right at the end, you've got a sentence about recovery stories, but you haven't said what you're going to do with them. Will be sought, will be heard, will be used for learning and development. And I wonder if you can just look at that wording, because at the moment it just says, well, it's not quite a sentence, Peter. It just needs sorting out.
I would, Chair, I'll feed that back to our North Yorkshire York colleagues who've written it, because I agree it could be doing with clarifying, couldn't it? Absolutely.
Thank you. Right, I have one more thing to say before we finish. I have talked to Tracy about pulling together our strategies in a list, and when we need to review them. We have quite a lot of strategies: autism strategy, carers strategy, and so on. And I'm not clear how many we've got and when we need to bring them back to the Health and Wellbeing Board. So I have asked Tracy to do that, and I'll bring that back to the board, hopefully as soon as she's able to get that done. No good having a strategy if you don't look at it every now and again. So that's the conclusion of the Health and Wellbeing Board for today. Oh, Sian, sorry, you want to say something?
I was just thinking, if we're pulling together a list of the strategies, would it also be helpful to pull together a list of the things that we have pledged to do? Because I know we have signed up to a number of pledges, just to make sure we're keeping ourselves honest.
Yes, absolutely. Can you liaise with Tracy about that one? Thank you very much indeed. Right, that's going to conclude the Health and Wellbeing Board meeting for today. It's been a most interesting meeting, and I hope that people watching and people who watch it subsequently on the recording will find it as interesting as I know all of us have. So thank you all for coming.